Trust starts in the first minute. People open up when they feel safe, seen, and not rushed. First impression, how we greet, look, and listen, set the tone for the whole assessment and shape what the person chooses to share. Hi, I'm Gladys, and today I will introduce the mental health assessment, why we do it, how we set it up, and a brief critique of the interviewer in the video. So, why we assess? What is the purpose and the approach? A mental health assessment has three simple aims: build a working relationship, understand the person's story in context, and create an initial plan that actually helps. We do this in a shared, recovery oriented way, explain the options, invite preferences, and make a plan together. So, start plainly. Say your name and role, explain why you are meeting, what will happen, and invite questions. State confidentiality and its limits upfront and check understanding. So in New South Wales, people must receive an oral and written statement of rights in language they actually understand. Also, choose a private, quiet space and control any interruptions. Environment affects engagement and decision making. Privacy and few disruptions support better assessment. Also, sit at the same level, no desk barrier, about 60-degree angle. This actually reduces power differences and helps natural eye contact. So, how to conduct the conversation? Begin broad and then focus, such as use open prompts, reflect on them, and then summarize. Move to specifics only after a proper rapport is built. Keep nonverbal communication warm but calm and do not overperform. Orient clearly at the start and close by reviewing the next steps and support. This fits the applause phases of the first orientation, then working, and then termination. In the video, the interview opens with name, role, and a warm tone, which shows good orientation and engagement. The nurse also discusses confidentiality at the start, which actually aligns with the guidelines. And the seating was at the same level with no desk barrier, which reduces power differences and matches Barker's advice. However, the room had slight noticeable interruptions. The literature recommends a private, low distraction setting. Furthermore, mid-interview, there were several close stacked questions that were asked. The evidence favors starting with open invitation and reflecting listening before narrowing. Bottom line, keep the warm, clear opening and structured closing. Strengthen the middle by maintaining environmental control, using more open prompts early, and stating confidentiality limits plainly with a quick check of comfort to proceed. Now I will hand this presentation over to Sangeeta.
Hi everyone, my name is Sangita Khatri and my student ID is 2078877. In this mental health presentation, I'll be discussing about question number 2. On opening phase of assessment, during the initial of Jake's assessment, the nurse and engaged with him in a calm manner to collect information regarding his hospitalization. She initiates the conversation with inquiries such as, "Do you know why you are here?" So creating a safe space for him to share his story. Jake reveals that he was brought in by his mother after a suicidal attempt, expressing feelings of despair that have persisted for months. He attributes his emotional distress to his recent discharge from the army, where he experienced trauma, including the death of a colleague in a landmine incident, and this traumatic event has led Jake to feelings of guilt and low mood, compounded by substance use as a coping mechanism. Nurse and aims to gather information to support Jack's recovery and suggest a hospital stay for further assistance. On establishing rapport and goals, the main focus of the presentation is Jack's suicidal attempt after his army discharge, exacerbated by guilt over a colleague's death. Nurse establishes rapport through empathetic communication, introducing herself, ensuring confidentiality, and actively listening and expressing genuine concern to Jack's story. The goal for Jack includes understanding his feelings, addressing trauma from his military service, and receiving support for recovery. Meanwhile, the nurse aims to assess Jack's condition by gathering accurate information to develop an effective treatment plan, ensuring Jack feels safe, supported, by facilitating appropriate care and fostering a therapeutic relationship that encourages his ongoing engagement in the care. This collaborative approach aims to facilitate Jack's recovery and overall mental health as well. Under recovery based and strength focus approach, the interview with Jack demonstrates a recovery-based strength-focused approach by prioritizing his personal narrative and emotional condition rather than his mental health challenges. Nelson emphasizes compassionate communication, validating Jack's feelings and acknowledging the trauma he experienced during his military service, particularly the loss of a colleague. This approach fosters a therapeutic relationship, encouraging Jack to express his experiences and emotions, which is crucial for his recovery. The conversation highlights the collaboration in developing a care plan that respects Jack's autonomy and promotes his healing journey. By focusing on Jack's strengths and coping mechanisms, the nurse facilitates a supportive environment that promotes shared decision making, ultimately aiming to enhance his overall well being and recovery path. This method underscores the significance of understanding the individual's context and strengths in mental health care, aligning with contemporary recovery oriented practices. Thank you.
Hi, this is Prativa Khadka, and I will be discussing the Part A of Body of the Mental State Examination. Some crucial observations can be made while conducting a mental state examination on a patient. Nurses can evaluate the appearance, behavior, affect, mood, speech, thought form, and thought content during the conversation with the patient. In this video interview, Anne could observe that Jake appeared tidy with appropriate clothing and slightly messy hair. He seemed to be avoiding eye contact and looking down throughout the entire conversation. His behavior was cooperative, but he seemed guarded as Anne needed to prompt him quite often. He was hesitant to answer questions initially, but he was alert, but not oriented to the day and the month, which reflected his cloudy thought content. For effect, he displayed an observable emotional state, which could be seen as sad and depressed. His facial and verbal expressions were congruent with his thought content. He maintained a flat range of voice with normal intensity and opened up slow and was in a depressed mood with active suicidal thoughts and ideations, and could observe that he was crying at the beginning of the interview and was persistently sad throughout the entire process. He maintained a normal rate of speech in a soft tone and spoke monotonously but with slight hesitance. His thought form was coherent and logical, and he admitted that he did not see things but only got flashbacks. The normal flow and organization of thoughts was reflective in his speech. For his thought content, there was no delusional thoughts, only active suicidal ideations. Being able to evaluate such traits of a patient forms up the first half of the mental state examination. So now I would like to hand over to my colleague Aman to discuss the second half of the body. Thank you.
Hi, my name is Aman Ali, and I will be answering question 4, where I'll be explaining perception, cognition, including memory, concentration, and recall, insight or judgment, and identifying risks. Starting off with perception, Jake has denied any occurrence of hallucination and delusions. He did raise issues about having disturbing nightmares and flashbacks about his colleague's death in the army, which shows trauma-related experiences. These intrusive symptoms are common in post-traumatic stress disorder and can significantly interfere with daily functioning and emotional well-being. In terms of his cognition, Jake was disoriented to the date and month, although he managed to correctly identify the year and where he was in that moment. His concentration was intact as shown when successfully performed the 07 task. His memory was slightly impaired as he was struggling to recall some events, but he still recalled his traumatic experience. Research shows that individuals with PTSD experience impairments in episodic long-term memory. These difficulties are particularly evident when compared with people who have not experienced trauma, and the impairment is often stronger for verbal memory tasks than for non-verbal ones. This means that while Jake is able to hold some information, he may continue to face challenges with recall, especially around recent or emotionally charged experiences. When assessing insight and judgment, Jake demonstrated partial insight by recognizing that his distress stems from his army experiences and guilt over his colleague's death. However, his judgment was impaired as shown by binge drinking in the days leading up to the incident and his impulsive overdose on Valium. Finally, the risks that were identified are significant. Jake recently had a suicide attempt and continues to experience low mood and post-traumatic stress symptoms. He misuses alcohol and feels socially isolated with no future plans. One of the protective factors in his situation is his mother, who remains involved in his care. Evidence indicates that people with PTSD have more than twice the risk of suicide compared to those without the disorder, with the risk being even higher among combat veterans. This highlights the need for close monitoring, especially in the early stages of hospital admission when the risk of another attempt can be heightened. From a nursing perspective, these findings highlight the importance of trauma-informed and recovery-oriented approach. Jake is to be on suicide monitoring, engaging him in therapeutic support and strengthening his protective factors, which is important in maximizing his safety and recovery. Nurses also play a key role in building therapeutic rapport, which can encourage Jake to engage with treatment and begin developing future goals that promote resilience. I'm going to hand it over to Karishma, who is going to conclude our presentation. Thank you.
Thank you, and hello, I'm Karishma, and I'll be answering the last question. The interview was ended in a respectful way, with the interviewer thanking the client, which supported a natural and polite conclusion. Despite this, the ending felt slightly rushed, as there were little emphasis on reviewing the key points or discussing the next steps. A more effective closure could have included a brief summary of the session, checking how the client was feeling, and offering an opportunity for them to ask any further questions. The interviewer's warmth and ability to maintain rapport helped the client feel at ease throughout the discussion. However, the closing stage could have been further strengthened by drawing attention to the client's personal strengths and engaging them in collaborative planning for ongoing care. Structured endings are essential in clinical practice as they reduce uncertainty, support safety, and reinforce a therapeutic relationship. In addition, adopting a recovery-oriented approach ensures the client is not only listened to, but also actively involved in decision-making. This promotes empowerment, increases adherence to treatment, and supports long-term well-being. Overall, while the interview ended respectfully, it could have been improved with a clearer summary, reassurance, and collaborative goal setting. A structured closure that highlights progress, acknowledges the client's resilience, and provides clarity about what will happen next would have further built trust and continuity. The next steps should involve linking the client with appropriate support services, arranging a follow-up to monitor progress and safety, and maintain open communication to ensure the client feels valued and supported in their recovery journey. Thank you.